Thank the conference organizers for inviting us from Uganda to participate in this conference. I'm making this presentation on behalf of my colleague Sise Mirembe, who was unable to get the visa to Canada. However, before I make the presentation, I just want to quickly go through her biography. She's a graduate of business administration from Accra University. She has been living with HIV for the last 7 years. She's a mother of 3 children, and all the children are HIV negative. And she's currently working with Mother to Mothers in Kiunga Health Center 4 in Iganga District. She's also the spokesperson for the Mentor Mothers Club under this implementing partner. Before she discovered she was HIV infected, she was a radio presenter in one of the local FM radios in the district. And because of self-stigma, she actually abandoned that job when she realized that she was HIV infected. So I'll proceed now to present this presentation on her behalf. Now, the mother-to-mother mentor-mother model is one of the many models that we are using for our community strengthening in Uganda. It engages what we call the expert clients. These are mainly beneficiaries of the PMT's services, just like Mirembe herself. And the attributes of the lay mothers that we identify and engage in these programs is that they should be HIV infected, recent people who have benefited from the PMT experience, and they should have disclosed to either their partner or one of their loved ones, and they should possess basic numerical and literacy skills so that we're able to empower them. So they are taken through a 2-week base training curriculum on their roles and responsibilities, and after that we engage them for 2 years and then release them so that we're able to take on other mentor mothers on board. And these mentor mothers are mainly used to relieve tasks from midwives to allow midwives to actually do their core functions. These slides actually summarizes some of the roles of the mentor mothers that we are currently engaging. They do demand creations in the communities, and they refer the mothers to the health facilities. Within the health facilities, they also undertake strengthening linkages, including escorting mothers to the relevant clinics where they need to go. They also help to identify unmet needs within these clients and then link them to where this can be met. In the health facilities, they're also helping us to retain these clients into care and enforce adherence through working closely with them, health education, and providing ongoing support. Beyond the mentor mothers, we also have other models that we are using. We have the village health teams that is recommended by the government of Uganda and Ministry of Health. And we have community agents in the community there that help work with us closely to track and create demand for this. We also have civil society organizations and community-based organizations that actually help us to create demand and refer these clients into the health facilities. Within the health facilities, we have facility-based community agents which work with the health workers to actually educate and provide services. And on your right are the indicators that we actually monitor to inform us about how the services are moving forward. We have what we call improving client retention through active client participation. This is really a model which we are using to follow up women, especially the clients that have missed a key appointment. In our health facilities, we have what we call a locator card, where we document the direction to these clients' home and also seek their consent to be visited at home. And then when they are lost to follow up, we usually have weekly meetings between the health workers and the mentor mothers, where we generate a list of clients that were not able to come back for their scheduled appointments. And before we visit her at home, we make a telephone contact with her about 3 times, because sometimes if you call once, the phone might be off because the battery is dead or it is kept somewhere. So we at least call 3 times, and if there is no response, then we make a home visit for such a client. The key scheduled visits that we are emphasizing currently in the program, the second antenatal visit, as Chewe said, in Uganda, our antenatal care visit, first one is very high. So we follow up the second antenatal care visits, especially for scheduled refills during pregnancy, and also the second postnatal care visits for scheduled refills. We also follow appointments for clients who are expecting to have a CD4 testing or expecting results, and ARV refills for after delivery. For those who have not come back for follow-up, we also follow them as well as testing for infants and infants who are due for heart. A quick snapshot on some of the outcome of this model over the last 1 year. We were able to follow 1,972 clients, and of which 83% were traced. The other 17% were not able to trace them because either they changed residence because of movements of the, specifically the partner, if he's transferred to work elsewhere, either they have traveled or they gave us wrong addresses. A few of them still give wrong addresses because of stigma and discrimination. But of those we are able to trace, at least 3/4 came back for review and received their services. Again, we try to see why did some of them did not come back even after we addressed them, and some of them still expressed stigma and fear to coming back. Others instead went to other health facilities to get their services. Others did not come because of long transport and lack of money, and probably because probably of other events at home. Maybe they fell sick, or they had a sick relative, or because of this. We had a few cases of ladies who got miscarriage and never came back, and I think this was because of a misunderstanding that maybe drugs are supposed to be for the benefit of the baby and not for herself. So some of this we had to cancel that, please, these drugs are also for your benefit. So even if you have a miscarriage, please come back for a refill. As I wind up, some of the challenges that we are still encountering is that most of our mothers still come late for first antenatal care. We still have low male involvement, and we know that male are key decision makers in our countries. The literacy among women is also low, and therefore it also makes it difficult to empower women to make their life-saving decisions. We still have a lot of violence, especially from the male partners, and then again we have a lot of migration within the country that sometimes hampers follow-up. And in this model, we are recommending that, actually, this is one of the models we are going to strengthen with support from SIDA. We want to engage community resource persons and opinion leaders to advocate for early uptake of antenatal care services. We also want to strengthen linkages between the health facilities and communities for more effective referrals. We also want greater involvement of the lay people, what we call the linkage facilitators, in integrated community outreaches activities to ensure a continuum of response, and then engaging a spouse partner. I think we have a good experience from Rwanda, which we are trying to borrow up. I think yesterday we had that. And then also wanting to minimize gender-based violence by integrating it into our programming. Finally, I want to acknowledge all the people listed there, and to say that this is Sise Mirembe, who was supposed to be here to make this presentation, and she was actually conducting health education in one of the health facilities that is working in. I thank you for listening to me.
Thank you, Godfrey, for delivering the presentation, and in absentia, thank you, Sissy, for preparing it and for your passion and work. So we're now going to have 3 presentations from 3 of the countries on the operational plans for the project. First of all, I'd like to introduce Dr. Frank Chimbwandira, who is the National HIV Program Manager in Malawi.